Hi, hi. This is the first presentation in the basically the mechanisms and manual therapy and dry needling. Really, this presentation was kind of genesis of it was an article that was first written on the mechanisms of manual therapy. But what you really see is that these mechanisms that apply in manual therapy for pain modulation that are the non-mechanical impact of manual therapy really cross over into the world of dry needling when you look at some of the research and presentations that are out there. So we're going to cover some of the mechanisms of dry needling, but then also in the larger scope of the picture, look at manual therapy as well.
Yeah, I think one of the big things to take away from this whole session is that dry needling and manual therapy are more than just a mechanical event. They're really a neurosensory event for the patients, and we can optimize that and use and capture that to make some good changes.
You know,
So we're gonna just kind
learning.
of,
Good.
yeah, we're just gonna go ahead and review pain modulation models and how that's applicable to dry needling. We'll go over some terms about myofascial pain, trigger points, what's the natural course of trigger points, and then we'll get into the local and central sensitization models and how needling can impact that. And then finally, we'll look at some systemic pain modulation mechanisms and have a couple cases at the end.
So this is a big, heavy diagram. This came from Joel Bolosky's article on again, the neurophysiological mechanisms of manual therapy. A really good article on the neurophysiological mechanisms. He tends to downplay some of the mechanical impacts, and that's kind of where I think he gets it wrong a bit. And that, I've seen it too much in my career and many of the manual therapists that there's definitely a mechanical impact in what we do, but it's not 100% mechanical. So many times a good manual therapist is going to interplay what is the neurophysiological mechanisms that I get from the manual therapy treatment, and sometimes they're purely mechanical with a little bit of overlay in the neurophysiological. So this model, what we're doing is we're setting the mechanical portion of it aside for the moment, and we're going to look at it. So big, heavy, confusing diagram here. But really where it starts here is in the bottom left-hand column where you see, the mechanical stimulus coming into tissue, and in that bottom left-hand corner, you see this can decrease spasm or, increase range of motion. But, the first mechanism will be in the peripheral nervous system is that the mechanical input, what we're talking dry needling, mobilization, manipulation, they even go so far and they include massage, or you could probably put in there some of the instrument assisted work. Peripherally in the nervous system, you're going to have inflammatory mediators, that are then released in the tissue. And these can either increase pain in the short term with a better long-term outcome, or many times even desensitize. These local mediators can desensitize the local tissue. So anytime we have manual therapy or dry needling, there's going to be this peripherally modulated response that's going to occur. And again, it's one of those things that can kind of go either way. It's where, sometimes, okay, I increase the inflammation, and then the rebound effect is I get greater desensitization. Other times it can be an immediate desensitization of the tissues. Within there also we have the spinal cord impact. So this signal gets to the spinal cord level, and here's where this works as the junction box. Now we can have at the spinal cord level, this can be mediated there as well, where there's a neuromuscular response at the motor end poles, the afferent discharges, and changes in the muscle activity that can occur. And this can be modulated at the spinal cord level. We've all been familiar with the gate theory of pain and how that works, and this works similar to that. But then also, the concept at the spinal cord level can also regulate the hypoalgesia, which is that temporal summation, is that, okay, we have these recurrent aberrant input where now all of a sudden we recruit a larger pool of neurons for the noxious stimulus. The mechanical input that we input in there through manual therapy, through dry needling, can help to intercede in this response. That selective blocking of neurotransmitters. So when we have that mechanical stimulus, we have that peripherally modulated response. It can also be modulated at the spinal cord level as well. And, we now look up in the upper left-hand corner here, look at the pain-regulated brain circuitry. Multiple areas of the brain are influenced, and this is mostly, kind of taken from medical imaging studies, whether it's PET scan, functional MRI, or kind of the two common ones they look at. And they look at the brain activity. They even use a transcranial stim now to look at the electrical activity or the magnetic wave activity in the brain to track this. So pain modulating circuits, we can kind of break it down simply. Think about a couple different levels. We have cortically driven pain modulation in the upper centers that we're aware of, can have descending inhibitory control. That idea that I recognize, oh, there's that signal, and that, that signal, that's nothing. That signal is just an itchy sweater that I can ignore. Or that, oh, that's actually a good sensation. Oh, I can feel my quadriceps muscle, and that awareness of it. Like, hey, that's normal, and creating this greater awareness that can occur within there. The midbrain level also has the ability. So we look at the midbrain level, there can be, non-specific or these in the midbrain level. I'm sorry, you can think about it this way. They often talk about here that like the PAG is a good one in that pain modulatory circuitry to talk about. PAJ, I believe it sends, serotonin and other neurotransmitters down to the spinal cord level, which raises the threshold. So what they find is with dry needling and even manual therapy is that you're going to get this release from the midbrain of serotonin and other, neurotransmitters, which can actually raise your pain threshold. And that's kind of why when they manipulate a thoracic spine, you can see decreased pain in a tennis elbow. You can see this non-specific, modulation of pain throughout the spinal cord with these stimulations. And you can kind of see now where there's some overlap once we get to these central mechanisms with, people will always ask you about, hey, well, how is this different from acupuncture? And a difference in our approach, but in many ways, some of the brain circuitry, there's going to be some overlap from the stimulus. But it's not to say that we're doing acupuncture. We're still doing dry needling in a medical model. This model then also applies to other techniques that we have available at our hands. Dry needling just happens to be a very strong form of neural input that we're able to achieve.
What I
Within
really
there
like about
also.
this slide,
Mhm.
what I
Oh,
really like about this
right.
slide is two things. One is the that pain modulatory circuitry, that descending inhibition, and the fact that if you think about this as a whole, as a clinician, what do we take away from this? Is that really all these mechanisms that you mentioned, the cortical, the spinal, the peripheral, and the local mechanical things, they're all those benefits and modulations and effects stack on each other. They don't really compete necessarily. They kind of stack. So if we, hey, can we group treatments together, needling, manual therapy, followed up with some repatterning of the brain now that now that fear avoidance and catastrophizing might be down a bit, to then kind of keep those changes going. And the last thing that just kind of popped in my head, and we'll get into this, I think, in a little bit, but is that pain pressure threshold. So, hey, one of the hallmarks of central sensitization is that the pain pressure threshold is lowered. It takes less pressure to cause a perception of pain. And that's one of the great things you see after both manual therapy and needling is that not just at the painful site or the needled site, but whole body, that pain pressure threshold increases.
Yeah, that could be again influenced by those last two boxes. The autonomic response is what you can see. Then also the endocrine response, which is the beta endorphin opioid response. Like that's that non-selective pain-killing mechanism that you see. And you kind of, you definitely see it with acupuncture treatment. So you have that patient who gets a little sleepy or is tired after a treatment, you needle them, just kind of wiped out and want to go home. They may be gaining a strong response. I do remember, I don't have the article, but years ago, I read one where they talked about they would basically pull CSF fluid out of one rabbit and be able to inject it into the other rabbit after dry needling and modulate the rabbit's pain. And it was due to some of those natural, non-specific painkillers that are released, not only, in the bloodstream, the spinal cord, but also in the CSF fluid, is what they saw. So you'll get this, this endocrine response as well. And, that's that individual that feels kind of sleepy or relaxed after the treatment. Again, maybe not what our first line, what we're going for, but it's good to be aware that that's that response that you see when we see it, because that's the individual where you know that, okay, if I needle them strongly, they may have, or do it with stim, they may have a stronger response. And I still want them to be able to drive home and feel normal for the rest of their day to do it. This is a good summary article of it here. And, this one just breaks it down, just a little bit further, or actually it's the same one in what we did in a sense, what we're looking at in these different modulators. So I don't know that I have much more to add to this slide.
No, I agree.
This one I pulled from I think it was manual, dry needling and manual therapy in a book. And if you look at it, this representation as we come in there, whether it's painful scar, needle insert and mechanical transduction, it talks to a bit about different fibers, but it's kind of a simplification of the last one we looked at. And this one again is coming from acupuncture-induced analgesia, where let's look at that needle insertion, that mechanotransduction that they'll refer to, which is a good term. It activates the different neural fibers, creating segmental inhibition in that lower loop. You know, that local trauma or C fiber activation, from the scar. Here it talks about, okay, where is that pain modulation coming in? Spinal cord, dorsal horn. That can then come back and also, it can reduce nociceptive inputs, through the targeted treatment of the needling. And again, as you see in here, the upper pathways that they talk about, where they'll talk about the five, the HT system, the opioid system, which is that endocrine system, that beta endorphin system we talked about, adrenergic system, and activation of descending neural inhibitory control system, which is basically this descending modulation where we can have descending inhibitory neural control, which is very common. That it's that itchy sweater phenomenon that, hey, we've had pain or we have irritation. Brain kind of starts to see this as, yeah, that's just noise in the background. Let me block that out. Let me wipe that away. Another example we often think about is that marathon runner who's able to run the, sub 3 hour marathon, but then, 2 minutes later they can barely walk. There's a bit of a descending inhibitory neural control that's going on in these individuals when you see this.
I always use the example of um, a soldier who is in a battle zone and is running to go pick up his buddy and carry his buddy out, gets shot in the leg, doesn't feel any pain in any way. In this case, there's real threat to his tissues and to his life. But because of this descending inhibitory pathway, there's no perception at all. It doesn't get up to the higher brain centers.
Yeah, these are good analogies. And we'll try and incorporate these things throughout it because these are great things to talk to patients. Patients are always asking, well, how does this work or why does it work? And, I like to give them a little bit of the science. So I know that, I know the science. And then I like an analogy right afterward, which says, hey, here's the kind of thing that you can kind of wrap your head around. So, being able to spew a little bit of science that maybe over their head isn't a bad thing, they know that, hey, you've done some thinking about this, you've done your research, but then give it to them in terms that they understand, I think is an important blend. Okay, at this point, it's good to talk about, okay, what is a myofascial trigger point in there? And this is going to be a hypersensitized fascicle of muscle in a very short term. And, really in two terms, they talk about active and latent in the traditional language. An active trigger point is going to be an area of hyperirritability in the muscle or in its surrounding fascia that causes the patient pain. There is recognized and nociceptive input from this tissue. That tissue is painful. You feel it when the muscle area stretches, when you move. It could be even when in inactive state. The latent trigger point is an area that is sensitized and it's tender, but it's only tender to basically palpation or stimulation. It's not hypersensitized where it's always there. I mean, we see plenty of people think about levator scapular upper trap. It's kind of that classic one. I have this point up here in my upper back, which is sore and sensitized. And again, as we get into the later modules, you'll see that okay, why is that? Understanding why that tissue is sensitized in that individual, reducing the stressor that's there, and then using these mechanisms to reduce the immediate pain for the best short-term outcomes. The latent trigger point is, okay, maybe I have something in my infraspinatus, which is associated in this pattern. And when I poke on that spot, it's tender or it's a taut band, but it may not be the primary pain that they're coming in with. So you'll see these latent trigger points in the balance of the system. Frank, any thoughts on this?
No, that sums it up pretty well. Yeah, like you said, I think it's important to be just aware of the terminology here. Again, patients are going to be asking you what is a trigger point. So having some science and also some comparison behind it to explain is helpful.
Yeah, I mean, oftentimes you may run into somebody with, let's think about this lateral hip pain, but they're gonna have trigger points in their hamstring because maybe their hamstring is hypertonic, controlling the SI joint or the pelvis because they have an increased anterior pelvic tilt or sway. They're standing in a mechanism by which that hamstring has to be on more when it should be going on and off or not be active. So they'll develop these either active or latent trigger points in a postural muscle that's doing a job outside of its normal bandwidth. And that's often where you can kind of predict which muscles these are going to be based sometimes on the postural cueing.
So as you
And
mentioned, the
again,
latent
go
trigger
ahead.
point doesn't cause any pain during normal activities. It's tender when you touch on it, but otherwise it is fine at rest. The one thing, it can also refer pain. So hey, if you push on that infraspinatus latent trigger point, you could get some referral of pain, maybe centrally to the thoracic spine, or even maybe out along the deltoid or along that C5 pathway potentially.
Yeah, because you can look at it that way. It's, along like a scleroderm point they'll talk about, or even along like the neural referral points through there. So you'll often see that. I mean, oftentimes you're going to get that, like, okay, you get the posterior knee pain with a hamstring trigger point. Be common. Think how often you have an L4, L5 referred pain, going into the gluteal region, where it's stimulating there. So, you start to think of your referral patterns in different regions. And, Terrell and Simons, they mapped out many of the referral patterns for these muscles, which, when you look at them, you know, many times they will make sense physiologically, but every now and then you'll needle one of these points, treat one of these points, and they'll get that sensation stimulated at that distal site. So I mean, it's not exactly what I look for all the time anymore, but if they get, hey, I'm needling the gastroc or the soleus, up, 2/3 up the calf, they're feeling it down at their heel. It's like, oh, I can see the relationship down in there, where they feel it. Those things will make sense. So you get these referred points. The idea that you're going to find these tall bands in these areas that are latent trigger points. They're maybe tender when you touch them, and again, and you can somewhat predict them, based on just clinical pattern and clinical reasoning. Somebody with a downwardly rotated scapula will have very classic over lengthened muscles and shortened muscles, whether it's, you look at different cross patterns of Shirley Sauerman you want to talk about, or Diane Lee, you'll see those muscle patterns kind of prevail. So you kind of predict them. Oh, definitions on pain, always fun terms. Allodynia, this is a lower than normal pain threshold. So somebody's been sensitized for a while, it's a clinical situation where pain results from a stimulus that should normally be painless. So you're touching somebody with light pressure, and their response is in disproportion to the amount of pressure. Somebody who's walking on a limb and the pain is disproportionate without physical trauma to the tissue than what it should be. They classically term it pain upon, palpation of 4 kilograms per centimeter squared, less at a site. Sure, all of you know that what that is in your finger, but you'll generally get a sense of with clinical experience that, hey, this one is not like the other. This spot is far more sensitive.
Yeah, and I think
And that's what, Mhm.
this kind of alludes to that pressure pain threshold as well. Hey, it should normally be higher than, in this case, 4 kilograms per centimeter squared. But because of these situations, the central sensitization, it's been lowered. The
Yeah,
next
this is
one,
different.
oh, go ahead.
This is just different than you think of it also being different than a traumatic injury. Somebody's a traumatic injury. There's a reason why that tissue, it's inflamed, it's hot. There's chemically mediated pain, there's tissue trauma. This is more of a sensitization that, okay, the tissue level of trauma does not match the level of sensitization. You can go and if you're ready, Frank, go ahead and get dysesthesia.
Yeah, so dysesthesia is really kind of a umbrella term. Any kind of unpleasant sensation um, to a stimulus. It could be numbness. It could be pins and needles. I've had a couple people talk about, feels like water dripping on their leg, um, but it's that kind of altered sensation that you typically think about when there's more proximal neural damage or compression.
And you'll see many of your patients, because it is kind of an umbrella term, your radiculopathy patients also have a dysesthesia. Your chronic tendinopathy patients, they can develop any one of these, or just an unpleasant sensation that's an expanded zone. It goes beyond the initial area of tissue trauma. you're recruiting in, collateral pathways and collateral neural networks around that area. Hyper Hyperesthesia, it's a greater than normal response to a stimulus expected, cause pain in a normal individual. So allodynia is very severe. Hyperesthesia is that, yeah, I do a light touch. Yeah, okay, that's painful. Okay, gentle pressure. Hyperesthesia, that's going to be painful. So what is going to be there? Because these are normal spots where whether you're doing dry needling or you're selecting a manual therapy technique, if you're looking at central desensitizing these individuals, the interesting thing that you run into here is like, okay, do I apply the stimulus to the area that is suffering allodynia or hyperesthesia? Or do I work a little bit peripheral to it and then come into it after I've desensitized them? Similar with needling is like you may end up doing dry needling to some of the associated trigger points or the latent trigger points, there's pots around there, and then come into the area that has the hyperesthesia secondarily after you've desensitized them.
Fibromyalgia, the kind of chronic multi-site widespread allodynia. So sensations that should not be noxious are painful and noxious at multiple places across the body. There's a whole lot of other things that go into kind of the fibromyalgia bucket. A lot of times you see a linkage with depression and anxiety, and which kind of goes hand to hand with some of that central sensitization. Something to be aware of, I'd say, maybe for the small percentage of patients who might be diagnosed with fibromyalgia, hey, that it might be they might be more appropriate for a more indirect approach potentially. If normal sensation causes pain, then maybe some indirect approach and working in down toward the site might be called for.
Yeah, here's where your needling approaches can be varied between needling these specific sites to doing the spinal segment where you'd be looking at maybe like a gun approach, which is okay, am I treating the neural sensitization or am I treating the peripheral tissue in that individual? If that's kind of where like you're gonna have a little bigger bucket of treatment techniques to figure out what may better match this individual. As we get further into, so we can discuss like what those treatment approaches may look like. Nociception is the neurochemical process by which pain signals are transmitted from the periphery or CNS in the individual. So you can have radicular pain, which is coming from the nerve root. Say you have a inflammation around the nerve root from a herniated disc or herniated disc compression on the nerve root will give you radicular or neuropathic pain. That's coming from the nerve, not in the peripheral tissue. Nociception is coming from the peripheral tissue. If I have a grade 3 strain of my hamstring, it's coming from the inflammation and irritation within the muscle. I have Achilles tendinopathy. It's coming from nociception from the irritation from the tissue and the pain fibers that are peripherally. So nociception I think of as coming from the periphery in that aspect, which is different from like a neuropathic pain or a centrally mediated pain, which may not there may be very little nociception now coming from the peripheral tissues. It's a more of a central pain. So we think of nociceptive pain. I like to really differentiate nociceptive pain from pain that's coming from the central nervous system or pain that's coming from radicular or irradiating pain or neuropathic pain, which is coming from the nerve. Conditions and these kind of some general terms on myofascial pain. Twitch response is a transient contraction is part of an involved muscle response to needling or a snapping palpation. So snapping palpation is if sometimes I go across my thing here and I can feel that band of tight, my extensor carpi radialis brevis, for instance, coming across my finger. I strum across there and I can feel that muscle kind of twitch as I do it because it's been sensitized. I'm going across what's probably a fairly active trigger point in that muscle from guarding, and it goes.
Jump sign you'll see occasionally. It's in general, it's a pain response of the patient who they could jump up, they could vocalize, kick a leg in response to pressure on the myofascial trigger point or dry needling as well. So this is the person that you're palpating the upper trap and you find that trigger point and they're gonna guard up against you. They'll make a face. that same person, if you put a needle in that trigger point, you might feel, number one, you would likely feel the twitch response. Um, and then sometimes that, someone might vocalize or move a leg in response to that pressure. And then, yeah,
As a
involved muscle is just the muscle that contains one or more trigger points.
And again, you have an idea key muscles versus secondary muscles. Certainly extensor carpi radialis brevis. If you're thinking like tennis elbow, looking upper extremity. If you're looking at like lower extremity injuries, yeah, you may have a gastroc strain, but the soleus may be involved. You may have hamstrings, peroneals, anything that may be along in there. If you're thinking along slings, is this muscle doing more to compensate for something else? So, am I trying to get increased push off from my gastroc soleus mechanism because I'm not getting enough, from my hip flexors? So, the involved muscle you can think of, but then, going in there, I always think of, okay, why is this muscle overworking either in the more normal thing, we'll say is a pattern of gait or daily activity. Some common characteristics of active and latent trigger points. They'll talk about common referral pattern with palpation. This has been mapped out pretty simply with, by Travell, Simons, were the kind of the classic ones who kind of looked at their manual and do it. And again, later modules, we're going to go over this a bit more. You're going to see a rise in acute or chronic overload and repetitive stress. And that's what we talked about. You know, Figuring trigger points, even needling. That's why we have such good, short-term results with dry needling, but the long-term results can be a bit iffy. And oftentimes it's because if dry needling is our a frontline treatment, then we're not clinically reasoning and solving what is causing the acute chronic overload in the tissue. So I look at dry needling as creating this window of opportunity to down ramp some of the acute pain that's currently there. And then once I do that, can I then retrain the motor pattern or the movement pattern, which is causing the repetitive stress
I think this
there?
is what you mentioned earlier, the example of the hamstrings having some trigger points, potentially feeling tight to the person. You and I have probably seen this 100 times over the years. The 45-year-old yoga practitioner who says, "Oh, my hamstrings feel tight. I stretch them and they still feel tight for 20 years." They don't actually have tight hamstrings. They just have increased tone and trigger points in an area, likely because pelvic floor, uh, the deep stabilization system, deep gluteal rotators are not doing as good of a job. So then, all right, you do some needling to address that tone, and then in that post needling period, post needling, post manual therapy period, you do some very specific repatterning and then loading exercises for the appropriate patterns.
Yeah, I mean, it's pretty common. I'll see, patients going to come in with, yeah, just as you said, it could be mid hamstring, restrained because the hamstring is hypertonic, trying to be a pelvic stabilizer and supplement that of the SI joint or doing it, or it's a firing delay pattern from the gluteal muscles. And there's a number of causes that can do that as we get into it. So when we do look at some of the common patterns for this, your immediate mind then goes into that, now you're the detective. Why is this muscle overworking when it should be doing a very normal pattern? What is going on in there and what is the compensation for it?
So one of the things you see, there's this um, increase in kind of muscle tension and with those active latent trigger points. And I think, like you said, I think we'll get into this with some later modules, but think about those Golgi tendon organs and muscle spindle cells. They just get kind of up ramped.
Oh, absolutely. Yeah, they're in a a little bit of increased tension all the time. That's why this muscle can be hypertonic, but when you test it, this muscle will often be weak and give. And it's not like a strength deficit. It's more of a pain or reflex inhibition that occurs than the muscle. Oh, a little bit of the natural course of we're looking at myofascial pain, caused by a trigger point. You're looking at, pathogenic factors coming in and causing the taut band or a stress, creating it. So you may end up with a latent trigger point at first, then progressing because this low load, long duration stretch into an active trigger point. So that idea that this person may be centrally sensitized, or they're using this in a postural way where you have this low grade tone beyond what its normal grade is. So how often do you see somebody with a very hypertrophic upper trap that's, basically hypertrophied, but it's also painful and weak. It's a very common one. We talk about hamstrings we see in the lower extremity. Oftentimes we'll see that in relationship to the glute, which may be inhibited. And so we're firing the hamstring first. Again, active trigger points. These things can happen from acute overload. Maybe I get a spontaneous recovery. Many times I'm going to carry some of these in anybody, and they'll be present in a lot of people without any real symptoms. That active trigger point, they can feel, it can go away. It can be just living as a latent trigger point for a period of time. But what we're looking for is that perpetuating factor. This person can't stay, they have a, classic example be like, okay, I have a 42-year-old, 43-year-old female where, okay, she's had two or three children, she's stabilized the pelvic floor with some hypertonicity or increased tone. She loses muscle mass as time goes on. This starts to fail a little bit. So you see increased maybe hamstring tone to stabilize the SI joint or the hip as she's moving. Another example is a runner with hip breakdown. So, okay, the hip starts to translate anteriorly or anteriorly medially, putting extra stress on the labrum or there, but it also increases tone in the external rotators, and the hamstring can be hypertonic to activate that. So you'll get these load conditions that will do it. Any conditions come to mind, Frank, in this pattern for you?
I think sometimes like you think about the shoulder and maybe the first rib. So hey, you can get some taut bands, posterior cuff, upper trap, levator scap, and then you add on top of that someone who, hey, well, one example is someone who the rest of the system, thoracic spine, scapula is moving really well. They might have a spontaneous recovery. Then you throw on top of that, maybe first rib is restricted, thoracic spine, maybe there's a little shift, or scapular control is poor. And all of a sudden now those taut bands, those latent or active trigger points, there's that kind of consistent and continuous noxious stimulation without any offloading.
Yeah, we kind of talked about this. So it's good to go over, okay. No, acute overload. Okay, some classic one here is going to be I have a 34-year-old male who's, just read Born to Run, and now he's trying to run on his forefoot, exclusively. So you're going to see the acute overload of, gastroc soleus and likely hamstring in this individual. So have they changed a pattern is what I'm looking for when I'm looking at a myofascial trigger point. That's somebody could, this person has changed a clear pattern. He could have inflammation. He certainly could have nociceptive pain from inflammatory mediators and muscle breakdown, and the tendon's not used to it. But certainly there'll be bands of these muscles in him which may be taut. So now all of a sudden his ankle feels a little bit tight because he's got tight fascicles within that band that's going to overload in that muscle. So an acute overload example would probably be something we're looking at like that. Do you, Frank, got a case for any one of these?
Yeah. So gross trauma, I've seen a bunch of people, especially playing squash, who down at the Maryland Club, they come and see me. Um, they've just had a partial tear of their Achilles or a lower partial gastroc tear. And as you're kind of triaging them immediately, and even a day or two later, the upper part of the gastroc and the hamstring have these active trigger points. So um, it's a little tough sometimes to figure out chicken and egg, but I think a lot of times, all right, there's this gross trauma that hey, you have a partial tear of your lower gastroc or your medial gastroc head. Um, all of a sudden, the rest of the body kind of the nervous system kind of has this big input and causes some of these bands to tighten up. The other one that I think a lot of us see a lot, and I think is an overlay with a lot of people, is that emotional distress piece. Um, you know, um, just like there's that descending inhibition, you can also have this descending activation or a lack of descending inhibition that keeps these patterns, flaring up. So that a lot of times, I'll see that more in like that upper trap region, neck, suboccipitals, um, even temporalis sometimes too.
Oh yeah, I mean, you see you'll see that a great deal. And that's kind of where this is like not so much that our scope of practice is, hey, we're going to manage your emotional distress with dry needling and manual therapy. They're coming in because they're having myofascial pain with it, but it's treating the whole individual. It's, okay, giving them some strategies to deal with the catastrophizing or the kinesiophobia or some of those pain modulators. Is it, working on breathing techniques to down ramp some of the neural tone? In conjunction with, hey, this person, yeah, if they're carrying this in their lower back or their pelvis, then it's going to be needling gluteal points, in the individual, because that's where the pain pattern is. So it's not deviating too far from, where our scope is. We want to kind of make sure that we're kind of within our scope, but it's kind of ranging when you have this emotional distress because they're going to have these painful trigger points associated with these areas of overwork or hypertonicity in
And
these muscle points.
I'll I with most people, and this has been, every year that I'm out more and more, I give some sort of diaphragmatic breathing, meditation, those kind of things. Um, with cases of emotional distress, clearly more of that. You focus that, hey, let's get the heart rate down, heart rate variability up. Can we kind of trigger that, or decrease the trigger to that central nervous system? And there's also, hey, if, I've referred people to have concurrent psychological therapy as well, if that is a larger piece too. But I think there's some great things we can do manually with dry needling, and also just with our words and our framing of the system to them that can help to modulate some of that emotional distress.
And joint and nerve, we'll get in that a bit later on too, like on joint modulation, we look at like osteoarthritis and needling techniques, which can be very effective in managing pain. And that's kind of where this presentation is important in the beginning to say, okay, where are we centrally modulating this? Because we're certainly not reversing the effects of arthritis. But we can change the tone around it. We can change the sensitization of the peripheral system. And again, there's even the argument too that by doing local needling, is does it change our peripheral modulation, some of those peripheral pain, chemicals and systems. So are we changing the local, pain sensitivity system versus the central pain sensitivity system? And many times with your stim techniques, it's kind of splitting the baby. But look, there's some, spinal cord mediated pain with at certain frequencies and other frequencies, it'll be more of a centrally mediated pain response. So we're looking to do that with those as well. And again, a lot of our techniques there with, try needling with nerve damage is going to be about, how do we stimulate the peripheral and centrally modulated system for pain? Because we don't necessarily heal nerves by needling along the dermatome or myotome point, but we can work in that desensitization mechanism to down ramp some of that centrally mediated response. Similarly with visceral disturbances. Okay, certainly, how many times you see back pain or facilitation of peripheral, the system with visceral irritation. All right, so what is a myofascial trigger point in its clinical features? Clinical features, you're going to see a contracted knot. So here, as you palpate, the palpation for trigger points is actually quite gentle. You really it's a rolling over the skin. Many times people take a finger, they do it like this, and they're driving their finger and like, oh, does that hurt? Yeah, oh, that's a trigger point. Well, everything hurts when I do that. Palpating a trigger point is going to be taking a finger and gently rolling it. I'm going to feel on the top of the skin. I kind of can feel through the skin layer, and I can feel that muscle layer underneath of it. And from there, I'm going to push gently into that muscle and go from there. So you can see I'll use a very flat finger, a flat tip, and I will push into it in that way. And once I start kind of, again, flexing the DIP and driving it in, you're probably going to kind of find a whole lot of trigger points because you're poking into people too hard. So for this one, we want to very, very kind of go through the skin layer there as he's kind of compresses the skin and then going into the muscle to feel that taut band. So overpressing is a very common thing that I see when teaching this initially. So you're probably very sensitive. You'll pick up more trigger points, but you're probably not very specific. Again, some of the local effects of a taut band are going to include you're going to get compression of the local blood vessels. So if I get compression of that muscle, those muscle fibers are taut. One of the concepts is that you're going to get compression of the local blood vessels, and are you reducing the oxygen supply to that tissue or region? This then increases the metabolic demands of that contractile tissue with rapid depletion of ADP as well. What we're going to see. So when you look in this model here, it's like, okay, it's going to be the energy system that will get impacted within this. So, you know, another response would be the local response. This is an end plate dysfunction hypothesis. So now we're talking about the neural end plate, the distal end of the nerve. And there's a presynaptic dysfunction, there's an intrasynaptic, and even postsynaptic dysfunction. So at the motor end plate, the calcium reabsorption, the ATP production, that whole cycle gets disrupted. So the end plate can become hypersensitized, from this local compressive response. That's what we see. So it becomes how this whole area communicates. So presynaptic, the motor end plate, the neuromuscular junction here in the really exciting version of this is the alpha motor neuron. The distal bouton contains, acetylcholine. Acetylcholine is released and binds to the acetylcholine receptor. And this allows the potassium calcium channels to move in and out of the muscle and cell membrane with a contraction. So this presynaptic response, this portion of that gets disrupted. With ATP depletion, ATP inhibits acetylcholine release, and this results with, again, here it's saying increased acetylcholine release. At the motor end plate, the end plate dysfunction hypothesis, the enzymes, the acetylcholine esterase breaks down acetylcholine. This acetylcholine, esterase deficiency permits excessive acetylcholine, which then accumulates at the synaptic cleft, is the problem now too. So now we're out of balance with the acetylcholine release or accumulation and the acetylcholine breakdown.
So the big thing with both of those that you have, to kind of break it down, is you have more acetylcholine in the synapse and postsynaptic, which is excitatory for muscle contraction. So you have this metabolic now sustained muscle contraction.
Yeah. So within there, this is kind of that model of where it's happening at the neural plate of why we see that sensitization. Again, there's nicotinic receptors, which just demonstrate increased response to acetylcholine. Again, it impairs the reuptake of calcium and increases the calcium release. And this increased calcium then leads to the muscle spasm. So, we can think about, does that muscle spasm, now being generated by what's happening at the end plate. So in essence, it's kind of like that idea that the muscle in some degrees can be, it's the servant, to the neural system. And in this neural end plate response model, the neural system and this, calcium and acetylcholine system is what's driving some of that muscle tone. So interrupting this system becomes an important component peripherally. Peripheral sensitization, and now we talk about what's going on peripherally at the nerve endings. Pain begins as nociception, as we talked about, from the afferent to A delta and the C fibers. Mechanical stimulus then and chemical activation, it's activation of these nociceptors. So we get that local, it's almost like a local stew. There's like, as we'll talk about down here, it's being sensitized by prostaglandins, leukotriene, substance P, and a myriad of different substances within the tissue, that now all of a sudden kind of increase that chemically mediated pain and sensitizes the system. So we could have, stimulation directly of these A delta C fiber nerve endings with this secondary cascade of chemically activated nociception and chemically mediated pain. I think it's a good differentiation here, but yeah, if I go and contract the muscle, it can be sensitized and I'm getting increased pain input through there. But that pain, that's that dull, lingering, aching, boring pain, and now that I contract it, it goes up. That's that chemically mediated pain. So when you think about pain responses, there's chemically mediated pain, and then there's also basically just the pain from the damaged tissue or the nerve fibers. Nerve fibers, those C fibers being stimulated by the stimulus. Any thoughts in there on peripheral sensitization?
Well, I think this is almost like that first, just to layer in dry needling. I think this is that first layer where, okay, you put the needle in, there's the mechanical stimulus. This is the first way that it then carries over to the nervous system. You see some of the reversal. Some of the studies are showing, some reversal of some of these things, decreased substance P,
Hmm.
an increase in the anti-inflammatory mediators. Um, to kind of help quiet that dull, A delta C fiber damage.
Yeah, triennially, they're 100% right. They look at that. They look at, basically, topography imaging of blood flow and, those different things. And the one model is that, okay, now you traumatize this area, there's an increase of blood flow. And then there's this washout of some of these chemically mediated substances. Now, again, it's, like all the research in PT, as you see, some studies will show that there's an increase in these substances immediately after the trauma, with then a washout effect occurring 12 to 24 to 36 hours later. So more aggressive needling, which you'll probably find, is that you're going to have an increase in local pain immediately afterward. If I'm using a more aggressive technique, it's good to tell them, hey, listen, you may be sore for the next day or so. What we should see is a balance or an improvement at the 36 to 48-hour mark, what we're going to
Mhm.
see. So for some individuals, you will increase this response in them immediately after needling, looking for what I like to think of as like the 2-day bounce. Other people, individuals, if I'm doing more selective dry needling, if I release the trigger point, increase the local blood flow, do I now then in that initial session create a decrease in the histamine and substance P concentration in tissues and create hopefully what we see is kind of a washout effect or a reset. And here's a list of just some of the other things you'll see in research as, that chemical stew, as it were, that creates kind of chemically mediated pain, bradykinin, serotonin, substance P, norepinephrine, calcitonin gene-related peptides, you know, tumor necrosing factor, and interleukin 1B. You see like calcium, gene-related peptide. It's only one that's common with the even like inhibitors of that is what's now common in the headache medication because I think that's related to the dural irritation that increased concentration of the CGRP is one of the mechanisms that drive it. So they'll give them one of the headache medications is something that inhibits this production, try to reduce it. So you'll see, these chemically mediated pain responses in a lot of different things, but these are also often implicated also in headaches and again around the DORA is one of the mechanisms. Central sensitization. This is persistent nociceptive signals lead to central sensitization. It's a pretty simplified statement of that diagram that we looked at initially, of how noxious nociceptive input can, it's going to affect multiple areas in the brain from, spinal cord and temporal summation in the midbrain to even cortical and our perception of pain and how our conscious awareness of this pain can upregulate and downregulate, that mechanism. We have neural plasticity at the dorsal horn and spinal cord. You know, this is where, okay, now we end up with the allodynia and the hyperesthesia and, some of the catastrophizing and some of the also the emotional responses that go on to that. You know, Another one that could be mentioned here would be cortical remapping of movement, which is very, very common. You see it in every shoulder patient, definitely common in the Achilles patient. The brain remaps pretty quickly, in response to the pain, how we walk, how we move, our neural recruitment pattern, for, essentially modulated movement patterns. So now you're into okay, I have the trigger point because I've altered my movement pattern to walk differently or reach differently.
You see this a
So
lot with chronic pain and that persistent central sensitization. In the brain with the homunculus, it's a pretty clear cut boundary, very crisp, clear boundary of what part of the brain stimulates or senses from what part of the body. Um, with this central sensitization, you get what they call smudging on the functional MRI. So that boundary between, hey, maybe shoulder and elbow or shoulder and neck gets smudged in the MRI. So now that proprioception and your cortical mapping of that area is off.
I have my a little ahead of myself there.
All good.
And again, central sensitization, this is kind of where we come in is thinking about we have neuroplasticity modulation also occurs at the spinal cord, the midbrain, and the cortical level. So, somebody comes in from, let's say 5 minutes, okay, I manipulate a thoracic spine, thinking, okay, they have a translation, subluxation. Was when a right rotation will go back to I manipulate it, great. They feel good right afterward. They're doing well. They come in that next session. My first question to them is, hey, you felt great. I feel awesome. How long did it last? Oh, I'm 80, 90% better. Doing everything. It's just a little bit of achiness and I'm doing better. Okay, great. That's a mechanical response. They're 80% better, doing well after I've done it. It's 2, 3 days later. Strong mechanical response. Hey, I manipulated. I felt pretty good. I felt pretty good that evening into the night, but kind of crept back in later on, a couple hours later, and the next day it was kind of, almost back to the same, maybe a little bit better. That is a centrally mediated pain response from manipulation. And I can see a very similar bounce sometimes with needling. Or hey, if I just go ahead and needle that paraspinal point, they feel pretty good right afterward. But then there's a bit of a washout effect that goes in over time. I mean, how often have you asked them, hey, you get massage for this? Oh, yeah. How was the massage? Oh, I felt really good. I did great. But later that night or the next day, it kind of crept back and I kind of feel like I'm back to normal a couple days later. I know that that was basically a neurophysiological response to the intervention. So we get to these people when they're sensitized. One, am I addressing the main driver of their pain pattern? But then also too, as we treat people, is like, how do I treat at these different levels? How do I modulate the pain at the spinal cord, midbrain, cortical level? And that's where movement-based interventions, dry needling gives us that brief interrupter of a strong input to stimulate the system so that I can restore normal movement, posture, flow, de-stress tissues.
One of the things I think it's important to consider is that, at least for me, when I was, going through school, first out of school, I, was taught about central sensitization, and I kind of, in my head, I think I had this picture that maybe we all had or have, which is the typical, hey, stereotypical patient, 40, 50-year-old who's had back pain for 5 years, maybe out on disability, super high fear avoidance beliefs, catastrophizing. Um, but the more I've been out, the more I see people, I realize that pretty much everyone has some level of central sensitization. It doesn't need to be the majority of what's going on with them, um, but addressing central sensitization and decreasing it with the varying things that we're going to get into, I think is important for most people.
Yeah, so there's so much more written on the patients. Here's them a lingering patient. Here's the person who's catastrophizing. How do you look at it? There's a lot more of that in the earlier PT literature. They've really gone away from that because when understanding central sensitization, how the pain responses, the emotional response to it. I think there's better stuff out there. And that said, is that it swung for a few years that it was almost too much on this, where everything is central, so everything is sensitized, and it's not really a problem, and you have to counsel them through it and coach them through it. It's like it's swung a little too far that way in recent years. And now
Yeah.
it's swinging back again as most things do. Manual therapy came back into vogue because of central sensitization, where, if you looked at the clinical practice guidelines in the JOSPT, manual therapy was moving down the wrong and was less popular. And then when it came out again about 4 or 5 years ago, manual therapy was back up in the game again as one of the key things you should be doing and why you should be doing it. It's mainly because of treating some of the peripheral and central sensitization mechanisms that they've seen that you saw in the article that we provided. And here it's like that's why manual therapy has come back in. There is the mechanical benefits from it. They're undeniable. But again, working in this central system with the tools that we have, along with the patient education and movement rate education, is this super powerful pathway. And dry needling and manual therapy provides us this nice temporary window to create the opportunity to kind of re-educate and work in that zone.
Yeah, I kind of think about it as kind of we're increasing that safety signaling to
Yeah.
then allow them to move.
Yeah, and what I realized too is if you linger too long in that modulatory thing, you also it's at our own detriment as well. If you're just used to the manual desensitization, then you get stuck in that negative loop of I'm doing manual stuff to them, modulating their pain, but they come back and they're not really any better. But this makes them
Yep.
feel better, so I get stuck doing it again. Where you sometimes have to be able to kind of go at some point and be able to, like Cortez and burn your ships and move forward on land, and get into the movement-based pattern of it to really desensitize them. So it's that fine coupling that we really need to work and, many times not get things that, hey, I made them feel great, but you don't want to be doing it 30 sessions in and kind of be stuck in the manual therapy loop. You want to be able
Yep.
to kind of break them out of that.
So this is a list of, I kind of think about it as the tools in our toolbox to help modulate pain. You have the local peripheral techniques. So ISTIM, some deep pressure, active release technique, needling, manual therapy, whether it's mobilization or manipulation. Um, we have the descending inhibitory control. You have that local gating at the spinal cord and dorsal horn. Patient expectation is another huge piece of it too. We'll get into in later modules. Part of the whole experience is the framing of it. So the education, the routine of it, and having that overlay, is crucial. You can have two people, needling somebody. One says, "Hey, this might hurt a bit," and then another one says, "Hey, you might feel this, but then it's going to calm the system down." The second person probably going to have some better pain relief at the end and not be as amped up. Um, we have some local healing effects especially with some of that inflammatory and anti-inflammatory release. And then again, the placebo effect is a real effect. But I think, the interplay of all of these pieces is where the art really comes into play.
Yeah, it's like, downplay in a sense that, oh, it's placebo with people, but you know what? If I have confidence in what I'm doing, if, hey, here's Jim over here, he's had needling, he's had a positive response. Hey, Jim, what's been your response to needling? I can manage the patient expectation. And can I stack the deck, not only in my favor, but also in their favor? Okay, how do I, if they have their mindset is that this is going to work, then research tends to show that they have a better chance of it working. So I don't necessarily want to leave that on the table or just be anecdotal about it. If I can stack their expectations, then it gives me a better chance to get buy-in. And many times I want to have them have confidence in me and build rapport. If they have confidence in me, then they'll do the next step that's going to help them. I want them to have confidence in what I'm doing and what I'm choosing because then, okay, I get better buy-in. They're more likely to do what they're supposed to do. They have a better chance of getting better. So that, but managing that placebo effect and building rapport and confidence is an important component of this. Key elements, local anesthetic. Some of the research show that if you have a local anesthetic to the tissue, believe it or not, there's no pain relieving effect with acupuncture. Now, this study, it was a bit older, so it'd be good to go back and look at some other things peripherally, but this is an interesting phenomenon just to remind ourselves that many times we're working in the neural system with dry needling. That in that case that we need an intact nervous system. So sometimes people have been desensitized in areas. And again, it's probably worth going back and looking at, it's always good. I think about every 6 months, go back and just do a PubMed search on dry needling just to say, okay, what new pops up? What am I missing? Is there anything else out there? Now there's probably hundreds of articles coming out every month. You don't necessarily have access to all of them, but just to see if there's any changes in the tide. Is there anything out there where there's been a, major shift in the paradigms? There's often not major shifts. Hopefully there's many times there's stuff coming out supporting what we've kind of seen anecdotally all along. Mechanical mechanisms, manual therapy, dry needling starts as a mechanical event. Pressure, stretch, tissue deformation. We're going to be stimulating mechanoreceptors, nociceptors. And this leads to afferent input, altered motor pull, tone, pain perception changes. So, the mechanical stimulus, whether it is manual therapy, dry needling, instrument assisted soft tissue mobilization, traditional massage, they're going to interact in the nervous system in similar pathways. But I think what we see the difference is that certain things are stronger than others. Manipulation is very, very strong with a modulatory tone. It's been proven there with temporal summation and decreasing pain at peripheral sites. Similarly with needling, we see it's a very, very strong input because it's such a different input. Our skin is used to having pressure and different pressure sensors. That needle stimulus is a much stronger, deeper input through the muscle receptor. So I think it takes a little bit higher order in its classification in the central nervous system than does, just pressure release or, acupressure, as it were. The local twitch response in dry needling is a spinally mediated reflex. There's this micro disruption of the, motor end plates, as we talked about, and how that impacts what's going on at the motor end plate. Increased local blood flow and oxygenation is also seen. That idea that local increase in blood flow and oxygenation decreases the concentration of inflammatory mediators and the chemical stew, as it were. So dry needling, sometimes we can think about, okay, I can go for the peripherally mediated response. I mean, my bias has always been more toward the central system, probably in how I was trained and how I view it. So I lean a little bit more that way, but it is also nice to kind of get a sense of, hey, I needle this person, why they would feel better almost immediately in the local tissue. And there's these local tissue effects that they'll see the increased blood flow and oxygenation. So I
The
just
one
also keep the open mind.
the one that comes to mind for me for that is for the local effects is maybe a tennis elbow lateral epicondylitis. You know, that is one where, hey, some more local effects um, seem to bring about some of that blood flow, oxygenation, and changes of the local things. The other thing I think is important, a bunch of slides back, a lot of the issues that pre, post, and intrasynaptic dysfunction had to do with a depletion of ATP, and one of the things with needling is that they found an increase in ATP. So it allows you to kind of bring in that calcium to stop that sustained twitch. Um, Calcium is one of those rate limiting steps. If you can't clear calcium, then your muscle is going to stay contracted a bit. So that increased local ATP and some via the perfusion is a very helpful response.
Yeah, real quick in manual therapy, joint mobilization affects collagen crosslinks, activating joint mechanoreceptors. Soft tissue altering the tissue, viscosity, improving sliding between fascial layers, other mechanisms by which manual therapy interact in the tissues and can get central input or also even peripheral input. Needling techniques. One technique commonly referred as kind of spinning, which is you take the needle and you manipulate it, it's just twirled within the fingers. And the idea of that is that collagen and elastin fibers wind around the needle, creating pull out force on that interaction. This is interaction with local fibroblasts, local nerve endings, and vasculature. So you're increasing the stimulation of that local tissue, also creating a little more micro trauma. So that micro trauma, if you're looking for like a local healing response, in a sense, you're getting a little bit more cells, a little bit more tissue that's being damaged. So increased in repair, increase in fibroblasts, probably aggregation in that area to create a controlled trauma in a tissue that may likely not be trying to heal itself. They'll talk about a local axonal reflex associated with this, and it's called a déquai. It's kind of a flush feeling. So sometimes people get this, they'll get this kind of flush feeling in the area with needle stimulation. Dull, achy, local. It can be local or it can be distal to the needling site, and it can refer down in those referral zones. With traditional dry needling, they always associate this with an increase in the effectiveness because the nervous system is being stimulated. The déquai, if you're feeling that locally flush and full feeling there or distal, that sensation is occurring in the central nervous system. So as much as, okay, wow, they're needling, my upper gastroc, but I feel it down on my ankle or my big toe or somewhere peripheral, that sensation in that area is affecting the brain and the brain map. It is not that, okay, now I have this nociceptive input coming in from my ankle and big toe. It's from the interaction of how the brain perceives it. Local tissue healing response is one, and that's one where the local damage the neuropeptides are released that may help promote healing. So the CGRPs, the vasodilators, the mediation of inflammation, you know, these different substances are released in the tissues, and this kind of, it's kind of like it's like a local trauma, and that also stimulates, one, the body release natural painkillers in that region, but then also local tissue healing to occur. So that's that local tissue healing model of dry needling. But then also, the peripheral pain modulatory system that can be enacted. So, a summary of peripheral neurophysiological mechanisms. Mechanisms stimulate a cascade of peripheral neurochemical changes. You have modulation of inflammatory cytokines. There's a reduction in peripheral sensitization due to these. There's an alteration in the local ion channel response, the sodium calcium channels. And again, reduces spontaneous electrical activity at the trigger points is the big kind of outcome with that. Again, the idea that manual therapy and dry needling begin mechanically, and the effects extend beyond the local tissue deformation with modularization in the peripheral system. Central mechanisms of pain and pain modulation. This is complex. There are multiple areas of the brain that are involved in this. Any slide or anything we do will be an oversimplification of it. So,
Yeah.
let's just start with there's a complex network of descending inhibitory pathways that are being stimulated. You know, the PAG is one of them. The periaqueductal gray processes for modulating pain signals, receives sensory information from the body and projects to perception and responses to upper cortical levels and has influences down lower. Apparently it's key. It's in fear, anxiety circuitry as well, motor control, and even cardiovascular and autonomic regulation. So stimulation in the PAG is going to alter cortical descending inhibitory control. We're looking at motor control and even kind of anxiety and apprehension, autonomic dysfunctions.
The
So
rostral,
thank you.
medulla. So,
Thank you.
yeah, so we picked these kind of, I think there's three of them here.
Yeah.
Like you said, it's very in depth, very complicated. I think it's important to know, hey, if you talk about the PAG with the patient, they're going to think you're speaking some other language, but it shows, hey, here's some information here, and it's helpful for you to know some of the mechanisms too. So the RVM, it's really key in that descending pain control. It sends signals to the spinal cord to change how those nociceptive signals are processed. It is also responsible for some analgesia in response to acute stress. So some of that reason why, hey, immediately after an injury, someone doesn't really have much pain. That's because of the RVM. With chronic stress to the system, and that can be stress, it can be mental, emotional, or physical stress. That RVM can contribute to the central sensitization pathways, and it's key in that stress response. And I think the last one, thankfully, is the dorsolateral funiculus. Has to do with fine motor control, locomotion, also plays a part in descending pain inhibition. So brainstem to spinal cord. This is where some of that endogenous opioid is released from. And it also plays a role in modulating pain-related behaviors. Uh, you know, limping, facial expressions, all of the behaviors that you see someone do when they're in pain is because of the dorsolateral funiculus, and it's been shown that needling can have some changes to this and the previous two.
Yeah, so this is where it's just nice to see that there's different areas of the brain. It is complex, but there's these overlapping areas, and that dry needling and manual therapy have been shown to kind of activate these areas of the brain and trace back to these areas of the brain being involved in it. So it's like we're standing on decent ground in our research, saying that, hey, here's how our treatments affect the central nervous system for pain. But then also, if we want to kind of in this area, hey, we want to improve somebody's ability to limp or move fluidly, by needling the muscle, reducing the trigger point. It's not only relaxing that trigger point to allow that muscle to lengthen and get better extensibility. There's a bit of release in the brain to go, okay, hey, this is kind of okay. It's okay for me to move this muscle. It's okay for me to do this. Oh, It's a reset, and it provides that temporary window for us to create that movement change.
One of the things you see with this is a lot in the psychological field with memories and fear is that in response to a kind of a reconsolidation or some event, you can recategorize how your brain stores that. And you see this with pain as well. So, okay, you have this pain, your brain says, if I go down the steps, my knee hurts. Okay, we do either some manual therapy or some dry needling, or optimally do both of them. We create this, as you said, this temporary window. It's a great phrase, temporary window for the brain to recategorize what that movement is. And then it's backed up with all these central mechanisms and opioids and everything else. And then you have this window of time after that to then do the repatterning and basically to rewire the brain um, to not associate, hey, stairs with pain, and now you can do these things and repattern and add strength and take away some of that central sensitization.
Here
So
again, it's just coming. Yeah, go ahead.
yeah, so this kind of sums up these areas, the central areas release those opioids, the serotonin, norepinephrine, together that inhibits nociceptive transmission at the dorsal horn. So that's that descending inhibition. Can we take that dorsal horn that has had some plasticity because of chronic and persistent pain and help decrease that nociceptive transmission? We have this decreased pain via manual therapy and draining. It's a neurophysiological recalibration. Um, and then the other good thing is that, hey, you can downregulate central sensitization via repeated peripheral stimulation and movement exposure.
Mhm. Yeah, that's what it is. It's not just getting locked into, needling is the strongest tool I have. Everything is there. It's okay, how do I couple these forces? How do I couple my movement and my needling? I'm needling these patterns, but then what's my movement pattern afterward? Where do I retrain the movement afterward? Is like probably just as important as getting a good needling sequence.
So one example could be, hey, chronic lateral epicondylalgia. Hey, they may have widespread hyperalgesia, so multiple joints. So there's some element maybe of some chronic central sensitization. Okay, we do some dry needling to the forearm extensors and maybe some joint mobilization to the radiohumeral joint. What you'll see often, we've both seen this. You get this local tenderness decreased, but then that pressure pain threshold is increased bilaterally, so away from where we affected. This is that slide talking about the article about the CSF transferred to one rabbit was needled, take the CSF from that rabbit, put it to another rabbit, and that second rabbit has modulated pain. You can also see pain relieving can be reversible with naloxone, with that endorphin, beta endorphin pathways.
Mhm.
And then if you do e-stim with dry needling, they've measured high concentrations of beta endorphins.
Yeah, it's different hertz. One hertz may stimulate more like PAG and spinal related mechanisms and at a different frequency. And we'll get into this a little later on. You're going to see more of a beta endorphin release. So oftentimes one is 100 hertz, the other one's like 4 to lower hertz. Oftentimes you'll see 15 to 30 hertz used because it's like splits the difference as it were. Oh, there we go. The
Yep, here we
slide's
go.
right there.
So
Low
yeah, so
frequency.
2 to 4 for low frequency. Um, I think I use this probably most often with needling and even with skin, with pads for e-stim. But that 2 to 4 frequency, you see the increased beta endorphin release, and enkephalin and orphanin. Um, mm, mm, mm. Some studies noted pain modulation with acupuncture dry needling without beta endorphin when performed without electrical stim.
So, you will get some of this release without the electrical stim. The electrical stim has been kind of seen to kind of increase this release. So that's kind of where you see electric stim be in vogue as far as just kind of it's like a force multiplier as it were as we do this. So by applying low frequency or stim, you can stimulate this mechanism stronger, but it's not required to stimulate the system. Some people this may get stimulated very, very strong with just needling.
So high frequency is going to be the 80 to 100 hertz. That's the typical pre-mod settings. You're going to see serotonin and epinephrine release. The big thing is you're going to see the pain gating response here, and then a little bit of descending inhibitory control as well.
Yeah, with sending inhibitory control, this is modulation of nociception at the brain and spinal cord level. Again, this serotonin pathway, receptors are stimulated by needling and electroacupuncture. Again, the A delta fibers are thought to facilitate serotonergic and noradrenergic systems. So just understand that descending inhibitory control is a big part of what we're kind of looking at with some of the dry needling, and part of the reasons why you need an intact nervous system many times to really get some of the good benefits from it. Again, PAG is the midbrain system, which is one of the modulators of descending inhibitory control we talked about a little bit earlier. Afferent pain fibers terminate in articulate nucleus in the hypothalamus. C fibers terminate in the limbic system. PAG activated through the hypothalamus and input from the limbic system. Increased activity in the PAG is also noted with electroacupuncture. So when doing the stim, it's kind of also stimulating this descending inhibitory control mechanism, which is kind of coming down to the spinal level, which is different than the other opioid or aponergic, which is that non-specific mechanism of acupuncture or not acupuncture, but dry needling, acupuncture, or with electrical stimulation. Yeah, norepinephrine inhibition at the spinal cord, descending, pain mediators from the PAG and the periaqueductal gray matter. Uh, this is throughout the serotonergic norepinephrine system. This stimulates amitriptyline, which inhibits the reuptake of serotonin and norepinephrine. So this mechanism basically, decreases the reuptake of serotonin and norepinephrine to increase the pain threshold locally. So this is that spinal cord mediated or that more local response from the PAG. Again, we've included some other slides in here for you. I think we can go in detail about this, but I think we're basically going to kind of really bore you. So we're going to include some of its other mechanisms in here that are included in the article just for your enjoyment. And again, integrating mechanisms here, you know, integrating mechanisms. We have a clinical case examples. Hold on a second, let me go back one. Good. Frank, you want to lead this portion of it here?
Yeah, so I want to go over two cases here. The first one, okay, we have this post-acute low back pain, maybe a 45-year-old male, subacute low back pain. He's got high muscle tone in his paraspinals. So, lots of guarding. He's limited flexion range of motion. Doesn't really have any of that, cognitive overlay. Not really. There's no real fear avoidance, no real catastrophizing. Um, so, when we check him out, we see that guarded movement, high muscle tone, no fear. So to me, this looks like a mechanically dominant case with a responsive nervous system. All right, there's some issues, maybe in this case L405, leading the system to then increase tone in the paraspinals. So what do we do? Um, all right, often we're gonna, all right, we figure out with our assessment that L45, we'll say on the left, is stuck in extension, so not opening. So we do a sideline gapping MOB or manip to L45, and then follow that up with some dry needling to the lumbar, multifidus, and paraspinals. In this case, we can do it with stim. And then that opens up that window that we talked about earlier, that kind of brief therapeutic window, temporary therapeutic window, where we follow that up with some retraining for proprioception and some neuromuscular patterning. Okay. For him, it was, hey, some hip hinge retraining. So we're going to pair this new sensory input with a safe movement pattern during this reconsolidation window. Oftentimes you see if we just stop at the manual therapy and dry needle uh, range, this effect is going to fade in a few hours. But if we add this end of the session, motor task, the nervous system resaves this new map of, in this case, flexion as a safe thing. So the mechanisms in this case, all right, we have the mechanical, so facet joint gapping, maybe some paraspinal tissue mobility, or there's an input to the tissue there. At the peripheral nervous system, okay, because of the manual and the dry needling, we have reduced inflammatory cytokines, that decreased spontaneous electrical activity, which is going to improve joint, tendon, and muscle mechanoreceptor modulation and improve proprioception of the area. And then centrally, you get better mapping, cortical mapping, some descending inhibition, and improved movement confidence. So, hey, immediately we have this improved flexion range of motion, and reduce perceived stiffness. We then take him through all these things. He does some exercises and some things for the rest of the day, the next day, and he has a big carryover for calming that nervous system down to not make bending forward so threatening. Yeah, anything you want to add to that one, Dave, or similar patients or anything?
Yeah, no, I mean, this one, there's a lot packed in here. It was a very common individual who's presenting with non-radicular pain. He's having nociceptive pain with no radicular pain, segmental dysfunction, L4, L5, and again, yeah, he's limited in flexion range of motion. I mean, you're probably looking at longissimus ilicostalis, hypertonicity. Multifidi in this individual could be inhibited. So, sometimes your needling is going to be, that's what is it? Am I needling for inhibition? Am I needling for facilitation? Well, sometimes you're needling for a little bit of both. Is it restoring homeostasis in the system? Is it getting input into the multifidi to stimulate them and go, you know what, it's okay for me to contract? Or if you're hypertonic and you're active in the longissimus ilicostalis, sometimes it's blowing the fuse box. It's getting that reset to allow these muscles to properly lengthen so this person, when they do flex forward, get the proper lengthening through the thoracic spine and lumbar spine for normal range of motion. Because, at the end of flexion, if you remember, there should be a flexion relaxation phenomenon at the very end where actually the longissimus ilicostalis and these lumbar muscles turn off when I'm reaching down and say I'm touching my toes. They will kick back on when I come up. But many times in these cases, like this individual, his high lumbar tone as he flexes forward is working against itself, and it's creating some of the problem. So that idea that I can use dry needling then to reset some of this neural tone, maybe get to that point of a natural flexion relaxation phenomenon with lumbar flexion, and restore that in this window becomes really, really important in this individual. And then their body gets that aha moment of, oh, it feels good to do this. This feels normal to do this. And getting that remapping in there. So yeah, needling creates that error in the manual therapy manipulation, creates that window of opportunity. Certainly, if this is a mechanical subluxation, you want to correct that, and that'll restore some of the normal input into the joint in there. But needling is super powerful and be able to reset some of that neural tone that's created around it. See if I get to the next case here. Oh, there we go. We got a
There we
second
go.
case there.
So this is, again, pretty common case. I try to have kind of two common ones. Chronic neck pain with that tension type headache. So she might have, maybe it's a computer worker, software engineer, something like that. 29-year-old female, had pain for 2 years. She's going to have that pressure behind the eyes, worse with prolonged computer work. Maybe she's done some massage and some Advil with kind of some short-term relief. Um, on assessment, we figure out, okay, CO C1 and C2, C3, mobility on the right is impacted. She's got increased suboccipital tone, upper cervical joint restriction, and in general, globally heightened sensitivity. So there's definitely a sensorily sensitized, but mechanically accessible case. So there's kind of a couple layers here. How does that impact treatment? Certainly, we're going to do some upper cervical mobilization manipulation. Um, my dosing might change a bit if she's super centrally sensitized. Um, I might I might not go right for the manipulation that I know will fix it. I might maybe start with more of a gentle mobilization. Maybe I do some oscillations. Um, then we'll go into some suboccipital and paraspinal dry needling. For this case, tell me your thoughts, but I think, hey, it's super sensitive, especially with neck things. I might just put a couple needles in for maybe 5 minutes as opposed to 10 minutes of needles with stim. I've often seen that for those sensitized patients, the dose is everything, smaller
Yeah.
mechanical inputs paired with larger kind of contextual safety cues can produce a bigger change. Um, so then important piece, and again, now we've opened up this temporary therapeutic window. Let's follow that up with some deep neck flexor and extensor activation endurance work, so maybe some upper thoracic mobility, upper posterior chain retraining. Um, so, we've kind of, we've decreased some of that threat for her, and now we're giving her those new patterns. So mechanisms here. Oh, I might actually add at the end of the session, probably some guided breathing, diaphragmatic breathing to work on that kind of vagal tone as well. So mechanical, again, three mechanisms. Mechanical, we've got some improved arthrokinematics at the facet joint. We've got, hey, if we with the needling, maybe some local healing response at the suboccipital. So we've, increased ATP, some better blood perfusion at the area to then flush out and wash out uh, substance P, some of those inflammatory chemicals. Peripheral nervous system, we've got some reduced trigger point sensitivity. So hey, those suboccipitals are really hot and tender, and after this treatment, that's been calmed down a bit. And then finally, centrally, we get this decreased temporal summation of pain and improved condition pain modulation. So hey, she might get some immediate pain reduction and improved deep neck flexor activation at the next session. So yeah, I'm trying to think. This is a pretty common one, I'd say. And I'd say just to echo myself from before, be careful with sensitized neck pain. I think lower dosing of manual and needling is a good thing to start off with.
Yeah, really has to gauge for that individual because right, if they have an impaired, occiput, head on C1 or C1 on C2 or C2 on C3, is it muscular, is it capsular, or is it an articular restriction and unteasing it? And again, needling can be very, very powerful in here. Like you're not necessarily needling suboccipitals. I mean, we'll cover an article in one of the cervical courses on doing the discapitis inferior oblique. But to get suboccipital tone down, I want to change craniovertebral setting. And what common pattern with this is that you're going to have splenius capitis, semispinalis capitis, the muscles coming up and attaching to the base of the skull, your longissimus, are all going to be your hypertonic facilitated muscles, your semispinalis cervicis, your deeper multifidi. Those are your inhibited structures. Your facilitated ones certainly be upper trap, levator, depending what they're doing. And as every research study shows, sternocleidomastoid activity will generally be higher and more active with movement than some of the deep neck flexors. But that has a lot to do with inhibition facilitation phenomena because you can manipulate or needle the cervical spine and you'll see a reset in some of that sternocleidomastoid tone and an up facilitation of longus colli, longus capitis in these individuals, which will then kind of regress back to baseline afterward. But you'll find that manual therapy has been shown to improve that facilitation. So are we always as weak as we think we are, or is this more of a retraining and neural retraining phenomenon we need versus I need to strengthen X and inhibit Y? Or really do I need to facilitate those deeper system muscles? So manual therapy, needling, super powerful in facilitating some of those deeper structures. And then the neck endurance work and the neck retraining then becomes very important. All right, this kind of concludes the first presentation in this series. We're going to move on to a few different topics in there. The next topic, I believe, is going to be, we're going to get into trigger points. We're also going to get into mechanisms, look at some of the mechanisms of manual therapy of lumbar pain. We're going to cover some of that because I think it's just super important to really think about, not only dry needling, but let's roll in some of the work of Paul Hodges, some of the other top researchers, and really look at these integrated approaches as we go forward. All right.